Good evening, good afternoon, good morning to everyone that's joining us today. It's very exciting to have you all joining us. We have over 300 people that are likely to join throughout the course of this Masterclass webinar. Tonight is the latest in our Masterclass webinar series, which is specifically focused at approaches to optimise use of outpatient parenteral antimicrobial therapy in the context of hospital and the home. So my name's Jason Roberts. I'm from the University of Queensland, and I'm director of the Centre for Research Excellence called Reduce. And this is an innovation of ours for this year, which has been timed, unfortunately, well in the context of COVID, whereby we've been able to adapt what our initial plans were to make it such that these webinars are available to a lot more people than would have been likely the case otherwise. So I'm sure a lot of you would agree that it's nice to talk about something other than COVID, and it's our pleasure to organise these. Of course, our first webinar this year focused on pulmonary infections, and most recent on infective endocarditis. And now tonight we'll be focusing on bone and joint infections. And then our final webinar for the year, which will be on the 26th of November, will focus on use of OPAT in the context of cancer patients. So I'd like to thank our sponsors which make this possible, and they are MSD, Pfizer and Baxter Healthcare. So thank you very much to each of those companies for enabling us to undertake these really important webinars. As a final aside, before I pass on to our chair for tonight, I'd like to let you know about a couple of other upcoming webinars which are unrelated to this particular series, but which may be of interest to those of you that are joining tonight. In late October, we are coordinating a webinar focused on antimicrobial susceptibility testing, which is providing updates related to what is the new information coming through from UCAST. And then in November, we're running a therapeutic drug monitoring of antimicrobials webinar as well. But that's enough from me. I'd like to hand over to Dr. Ben Rogers, who's from Monash Health in Melbourne. Ben's an ID physician. He runs Australia's largest OPAT service, and is one of the great originators and thinkers in this area, and has contributed a lot to these masterclass webinars. And so it's great that we can have his expertise and insights as a chairperson to lead us through tonight's webinar. So I'll hand over to Ben. Ben.
Thank you so much, Jason, for the very kind introduction. I think some of it was a little bit too kind, but I'm from Monash in Melbourne, and as Jason said, I run a hospital in the home program and an ID physician and clinical researcher. And I think it's just fantastic that we've got this bone and joint webinar tonight. We've got a really good speaker lineup, so I'm not going to spend too long really taking up the time before we move on to Ed. But I guess, I just wanted to make a few starting remarks. And thinking about this webinar as we were planning it, one of the things that really strikes me is that in the OPAT space, the patients that we manage with bone and joint infection are really one of the most varied groups that we come across, compared to endocarditis or compared to our central nervous system infections or other complicated infections. It's really a very varied patient demographic. They have some of the most varied pathogens. They have some of the most varied aims in terms of what we're actually trying to achieve with their treatment. And I would say, having been through quite a few hospitals in Australia now, there's some of the most differing and variable local practice relative to other types of infections. And I think our speakers today are really going to look at a number of aspects of care and really look at the science that's been emerging around these aspects of care, but also, at some of the practice and experience and how to really meld those two together to do the best for our patients. It's also a very rapidly changing space, bone and joint infection. Most of you will know about OVIVA and the studies of oral therapy, which hasn't really got rid of OPAT. It's changed, it's just in some instances changed the way we think about using OPAT. Whilst it's nice to have a talk that's not on COVID, I think personally, COVID has also really changed the way we think about OPAT as well for these patients, and changed the way we, approach their care, and change the way we approach oral and intravenous therapy. So, you know, that's kind of going to be an elephant in the room to some extent. It's going to be something that kind of cuts across everything we're doing for quite a while now. So without really too much further ado, I'm just going to pull up my right document here. I'm going to introduce Ed Raby, who is a consultant microbiologist and infectious disease physician from Fiona Stanley Hospital in Perth. He works in both microbiology and infectious diseases, so brings that really useful lab aspect to this area, and he has a clinical interest in skin and soft tissue infections, burns and diabetic foot infection. And Ed's really going to tell us tonight why bone and joint infections are so important to treat on OPAT services. Let's see if we can find, can you see us there, Ed? There we go. Actually, I think you're on mute. I think.
So there's the mute, and now
there we go. We can hear you now. That's perfect.
And now the screen.
While Ed's setting this up, I'll say that we'll probably aim to hold questions till the end of all the talks rather than jumping in between them, and we'll make sure that the questions go to the appropriate speakers.
Good evening, good morning. So I'm going to provide a very much an overview, and I think leave more questions than answers as we run through a very brief history of bone and joint infection treatment, the rationale for prolonged therapy, and some of the concepts around the choice of treatment and treatment duration. And as Ben highlighted, this is a very broad and heterogeneous group of infections, including both septic arthritis and osteomyelitis, with osteomyelitis further broken down into usually acute hematogenous infection involving particularly long bones in the groin bones of children, and more the axial skeleton in adults and particularly in the elderly. And it can be more complicated as we throw in prosthetic material, neurovascular compromise, and when infections are fracture related. There's a dichotomy of acute versus chronic infection, particularly in the osteomyelitis setting, which I think we need to try and pick apart a bit better. Our infection management is, from an antibiotic perspective, is further complicated by taking into account the surgical management, which involves debridement, which at times is limited to try and maintain function, dead space management, which may or may not include the use of local antibiotic delivery devices, soft tissue reconstruction, which is increasingly recognized as essential to be conducted early to try and provide reconstruction of that soft tissue envelope to contain the underlying bone and promote bone health, revascularization when that's required, and stabilization, which may be internal or external. So really very complex field of medicine. If we go back and look at what the Egyptians described, they certainly did recognize osteomyelitis as an entity, and describe their management including drainage, debridement, and coverage with meat. In their setting, this wasn't fancy plastic surgery, but just good fresh meat was used to close the wound until it healed. I'm not sure what's being delivered here, but I think this unfortunate patient might be about to receive clindamycin, multiple capsules a day, which is potentially not optimal for every patient. So we're moving quickly into the early last century in the advent of antibiotics. Of course, some of the sulfa drugs came first, but then penicillin emerged as the drug that was able to not only provide cure, but also save lives. So used initially, the descriptions were of use in children with treatment regimes of anywhere from 1 week to 1 month, with majority of them actually receiving about 2 weeks of therapy, an excellent success rate. So clinical cures of 80 to 100% described, and mortality going from about 15% to nothing. In contemporary case series, the mortality rate of these infections was about 15%. And with the advent of penicillin, they suddenly saw deaths evaporate with no deaths at all. Subsequent studies in the middle of last century describe long-term success, with about 90% achieving long-term follow-up success with cloxacillin and cefalexin. And this is when we start to see a dichotomy with chronic and acute disease, and acute being treated with at least 3 weeks of treatment, whereas chronic osteomyelitis being treated with up to 3 months or more of treatment. Although the authors at the time do describe the difficulty in clinically defining acute and chronic in some cases, and the reason for the duration difference isn't entirely well described. We then move on to the 1970s, and Francis Waldvogel and his colleagues wrote a seminal series of articles in the New England Journal of Medicine, where they defined adequate treatment as 4 weeks of high-dose parenteral beta-lactam. They also introduced the concept of bone penetration. So I think these were very important papers that really set the standards for treatment, and some of the dogma which has persisted. Moving on to the 1980s, and we see the introduction of the quinolones. And for the first time, people are describing similar performance of an oral agent, so the oral quinolones, to parenteral beta-lactams in some small randomized controlled trials. At that stage, the studies had no prostheses, and it's really not until the end of the last century where prosthetic joint infection became a recognized entity as a real emerging problem. And similarly, study in 1998 conducting a randomized controlled trial that identified the importance of biofilm and the potential use of rifampicin in conjunction with ciprofloxacin to provide improved outcome for prosthetic joint infections. I think it's very important to note that that randomized controlled trial contained only 33 patients in total, so a very small trial, but that has defined a lot of the subsequent treatment of prosthetic joint infection. Moving through to 2012, we have the CID article by Spellberg and Litsky that they again describe beta-lactams having, this paper very much focused on bone penetration as the most important aspect of identifying agents for treatment of osteomyelitis. And they highlighted that beta-lactams have poor bone penetration, but this can be circumvented by providing parenteral dosing to achieve adequate exposure. They then did not look at the clinical outcomes of any of the oral beta-lactam studies, focusing then on high bioavailability drugs that were also able to provide high penetration of bone, and focusing on those as suitable for oral therapy, with trimethoprim sulfamethoxazole and clindamycin being their preferred agents for gram-positive infection, and quinolones, as well as, again, the trimethoprim sulfamethoxazole for gram-negative infections, metronidazole for anaerobes, with then doxycycline and linezolid as other agents that may provide alternatives with high bioavailability and high penetration. They also go on to say that the addition of rifampicin should be considered for all implant infections and also for chronic osteomyelitis. They tried to assess the optimal duration of therapy, but identified that this was poorly defined. The standard 4 to 6 weeks has little evidence base, but there was nothing to say that longer would be any better. The 4 to 6 weeks they identify as being very much tied up with the belief that 4 weeks is the time that it takes for bone to revascularize. Subsequent Cochrane review in 2013 identified only 8 small trials involving a total of 282 participants with chronic osteomyelitis, none of which were high quality and unable to provide any clear rationale for either the correct agent or the duration for treatment. So this is where we're at with the Australian Therapeutic Guidelines, a table that I expect a lot of you would be familiar with. We're defining intravenous therapy and the total therapy, combining intravenous and oral therapy. The 2 to 4 weeks with a total of 6 weeks is where we kind of stuck here. Although there are notes to adapt the treatment duration to clinical response and considering an early switch if there are suitable oral agents with high bioavailability available. There's also a note that vertebral osteomyelitis may need longer treatment, particularly if there are undrained collections or if MRSA is involved, based on some recent studies. And then came Oviva, which Ben has already mentioned. I've just pulled out a couple of things here, more just to pique interest rather than to highlight anything in particular, but I think it's important to note that this study, there's a lot of prosthetic joint infection in here, so you can see a predominance of staphylococcal infection, both Staph aureus and coagulase negative staph. We don't know exactly which organisms match with which antibiotic regimes, but of the 40% or so of quinolones that we use, 80% of those were associated with rifampicin use as well, so presumably predominantly Cipro and rifampicin being used for staphylococcal infection, and then a smattering of other agents. There was 15% penicillin use. Again, we're not sure exactly what that is, whether that's Fluclox, Cefalexin or Augmentin. There were somewhere between 15–20% of these patients had diabetic foot infections, but there was no clear signal that penicillins delivered orally were any worse than other agents. But obviously subgroup analysis and difficult to make any clear conclusions from that. I'd just like to highlight some recent work from around the world. So out of Finland, Parkkonen and his colleagues, Paloitra and others, have done a lot of work looking in the pediatric bone and joint infection space, identifying clindamycin or cefalexin as having excellent outcomes, including in those with staphylococcal bacteremia, which I find interesting as an adult physician. May need one of the pediatricians to comment on that later. Out of the Netherlands, they're describing a flucloxacillin oral absorption test, which has identified wide variability in flucloxacillin absorption between patients. And interesting, not so much the food effect that is in our general psyche is that Fluclox administration with food is very detrimental, and that's not so clear out of their studies. They're saying that they're routinely using flucloxacillin for step down in bone and joint infections, although their outcomes are not yet described. Out of New Zealand, Professor Begg and his colleagues have recently described the PK/PD aspects of flucloxacillin given with probenecid orally, so oral Fluclox with oral probenecid. Although the levels are not much higher, it massively increases the some of the PD parameters at the, potentially at the bone level, which may make it a more useful agent in this space. And Ilko Iske and his colleagues in Switzerland recently conducted a narrative review looking back over all of the older papers describing oral flucloxacillin and beta-lactam therapy for bone and joint infection. And their conclusion was there was no clear association with clinical failure above and beyond what you'd expect with any other, so success rates in 70 to 90% of patients. But again, poor quality, small trials, and further trials should be undertaken in that space. I thought this was quite a neat meta-analysis where they looked at the available evidence in terms of duration of therapy. Their concluding algorithm suggests treatment pretty much in line with what would be our standard, with shorter treatment for acute osteomyelitis of childhood, and then for everything else about 4 to 6 weeks. they did note that there's various definitions of short in the literature, being less than 3 weeks, less than 4 weeks, or even less than 6 weeks as short. And there's only a limited number of studies that directly compare different durations of therapy. It's, I think, 5 randomized controlled trials and about 10 observational studies. And again, suboptimal quality, heterogeneity in disease. In their meta-regression, they identify Staph aureus infection and vertebral osteomyelitis as potentially needing longer duration to increase chance of success. But really what we're seeing is a consistent message that these patients probably need at least 3 weeks and probably up to 6 weeks as the standard duration of therapy, which makes it appropriate for prolonged outpatient therapy. I also just wanted to quickly highlight some of the questions around this dichotomy between acute and chronic osteomyelitis. So here we've got a series of histopathological images going from, on the top left in A, acute osteomyelitis with small aggregates of neutrophils, and then in B, again, an abscess seen sort of down to the bottom of that picture with the pink arrowhead showing sequestrum. So in my mind, sequestrum is chronic osteomyelitis, but in a histopathological level, we've got sequestrum on the microscopic level in what they're calling acute osteomyelitis. C is starting to see a mix of both acute and chronic features with a sinus developing up at the top of the picture. And then through the bottom panels, increasing the chronic picture with lymphocyte predominance rather than neutrophils. And on the bottom F, this irregular periosteal reaction that would be much more typical of chronic osteomyelitis and is a feature that we would start to see on x-rays after about 2 weeks or so. So the clinical dichotomy traditionally taught as somewhere between 2 and 4 weeks you move from acute to chronic, and that does align to some extent with histopathology, but the histo is a mix of disease on the microscopic level where you've got sequestrum, you've got acute features, you've got some of the chronic features, and often they will describe acute and chronic together. Bone penetration is, I think, a very difficult field of research to interpret. Certainly with my microbiological hat on, the target to me remains very unclear. We're talking about cancellous bone, we're talking about cortical bone. When you're in the joint, it's the synovial tissue or the fluid. What's the contribution of intracellular, and how important is it that we're using agents that can get into that intracellular space? There was some suggestion that osteoblasts were important, but it's probably more a macrophage Trojan horse that's contributing to some of the chronicity of infection. When you get into the biofilm, we need to think about the biofilm matrix, as well as the metabolic changes that happen with the bacteria, and what's the effect of that on the interpretation of an MIC. Methods of analysis, I think, are also difficult. Most of these studies have been done on healthy bone rather than diseased bone. So specimen selection, the collection, the processing, heat processing, and as you're grinding has the potential to degrade antibiotics. And then the assay that you're using, we're looking at free drug, we're looking at bound drug. I think all of this makes interpretation of these studies very difficult. But in essence, most of the studies that have looked have found what appear to be adequate levels of most drugs in bone, apart from penicillin in the bone and flucloxacillin in the joint. But then we see clinical success with those agents. We also know that they have a high therapeutic index. We can deliver very high levels of these in the serum. So is a poor serum ratio that relevant? I don't know. I think that's very difficult for us to interpret at this stage. And also, it's not just biofilm. Biofilm's classically described in prosthetic joint infections. It's probably also occurring in more chronic infections where we've got down the bottom series there, there's osteocyte lacuna canicular network invasion. So you can see in panel M there, that's one of those tiny little veins through the bone. Sorry, not veins, one of those tiny little channels through the bone, and the staph have actually invaded in there and are quiescent in that space, which is away from the immune system. And along the top, we've got a staphylococcal abscess community developing where, again, the metabolism has changed, the environment has changed, and so antibiotics are going to have to work differently in that space. Bioavailability, again, I think this is difficult to interpret. We know which drugs are bioavailable and which aren't. In particular, when we're looking at amoxicillin, amoxicillin has good bioavailability unless you really crank up the dose and things start becoming non-linear. But once you add in the clavulanic acid isn't so bioavailable, but is that important? Do you need them both? And once you're getting down to the bone level, it all becomes a bit more tricky. We know that a lot of our patients will have comorbidities that are going to affect both bioavailability and exposure. So those with cardiac failure or other causes of edema will often have an element of gastrointestinal edema, which is going to reduce bioavailability. And interesting, there are some studies looking at gastroparesis, again, common in our diabetic foot patients, and gastroparesis has been shown to reduce ciprofloxacin bioavailability significantly. And then as we move into these other oral agents, there are clearly issues in terms of drug interactions. And tolerability. A lot of patients won't tolerate oral flucloxacin at high enough doses, and consistently rifampicin, about 30% of patients have to discontinue their rifampicin for a variety of reasons, not just liver toxicity, but other issues as well. And adherence to oral agents, particularly if we're asking people to continue these for 6 weeks or so, Avivo self-reported adherence, and only 50% of their patients had what they termed high adherence. In other RCTs, it varies between 60 and 80% adherence to every dose. Do we need every dose? Can people skip doses? We don't know. And finally, the issues around stewardship on OPAT. I think there are clearly some threats to antimicrobial stewardship. Preference for daily dosing pushes some people to use broader agents than are required, such as ertapenem. And then on the converse, using agents because they have the right high bioavailability, the right bone penetration, will often lead us to using more broad spectrum agents than required. Some questions around stability that will be discussed later in this seminar. There's also some opportunities for us to optimize particularly narrow spectrum beta-lactam use. And I think that's not just in terms of using IV when we can, but using oral more wisely as well, presumably with increased levels of TDM. And also to intervise the duration of therapy, so not just using blanket long treatment courses for everyone. So bone and joint infection, we've got a wide variety of patients here with a wide variety of illnesses and a lot to cover in 20 minutes. But what we do know is that OPAT is considered safe, cost-effective and acceptable as compared to intravenous inpatient therapy. It is complicated. We've got a complex patient cohort, and the evidence base for selection of agents or specific durations for bone and joint infection is hampered by low quality evidence and small numbers. But I think there's a real argument here to start moving towards outpatient personalized antibiotic therapy, where we're looking at selecting the right agent for the right person with the right infection, and monitoring that more complex antibiotic regimes in more detail in our more comorbid and more complex patients. Back to you, Ben.